Hello, my name is Sarah Keene. I'm a nurse practitioner here in the Norton Multiple Sclerosis Clinic. A question that I get asked frequently is, what is multiple sclerosis? Multiple sclerosis is an immune-mediated problem in the central nervous system. Specifically, it involves the immune cells causing damage to the myelin sheath in the brain and/or spinal cord. Essentially, the immune cells at some point developed a bad habit, and instead of attacking things in the body that should not be present, the cells start to cause damage in the myelin covering within our own brain and spinal cord. The reason that the immune cells make this switch from behaving normally to attacking our own bodies is not entirely clear. There are thought to be many factors involved in causing this glitch in the system. Some of the factors that may play a role in developing this autoimmunity may involve viral exposures, environmental exposures, vitamin D levels, or even potentially where we live in the world. When I think of the immune system, I think of a tree. The immune system is a large and robust system. I think of the trunk of the tree as the white blood cells. Each branch from the trunk represents a different type of white blood cell, each type having a different function. In multiple sclerosis, I look at the branch of lymphocytes. The role of lymphocytes are to recognize antigens or things that are not supposed to be in the body, such as certain viruses or bacteria, and then work in various ways to rid our bodies of the substance. In multiple sclerosis, I look even further outwards on these branches, specifically the B and T cells. Lymphocytes are all born in the bone marrow. As lymphocytes are differentiating, growing up or maturing, if you will, some of them remain in the bone marrow until they are fully developed. Those would be the B cells. T cells are a little different. As T cells develop, they move from the bone marrow to the thymus to continue to develop and mature. The thymus is where we believe T cells learn to fight infections. When I think of how B and T cells typically work together in the human body, I picture them as a team, though with different functions. I like to think of the B cells as the cells that are in charge. B cells are the lead commander during a battle. The B cells are giving direction to the T cells and telling the T cells when and where to attack. The role of T cells is then to follow the instruction and destroy the substances that should not be present in our bodies. At some point, either the B cells or the T cells or both have learned a bad habit or have mislearned an instruction. At some point, the cells then turn their focus not only toward substances that shouldn't be present in our bodies, but also begin to recognize the brain and the spinal cord as something to be attacked. How much damage occurs to the brain and spinal cord during these assaults can and does vary greatly from attack to attack. The symptoms that a person experiences during an attack or relapse are a result of where the attack occurred in the brain or spinal cord. It's important to understand that there are different types of multiple sclerosis. The most common type of multiple sclerosis is relapsing remitting multiple sclerosis, meaning that these attacks or assaults on the central nervous system come in waves. The immune system causes damage to the brain or spinal cord, though over time the attack subsides and symptoms may show some improvement. There's another form of multiple sclerosis, progressive multiple sclerosis, where the attacks are much more insidious. The symptoms from the assault come on much slower and typically do not improve. Over time, a person with progressive form of multiple sclerosis may accumulate more symptoms or worsening symptoms without clear evidence of new assaults on MRI. Now that we've discussed the role of the immune system in multiple sclerosis, it makes discussing the role of disease-modifying therapies a little easier. When caring for a patient with multiple sclerosis, we have many jobs. The two most important jobs are to, 1, prevent further relapses or attacks and disability accumulation, and 2, help manage the symptoms associated with previous damage to the brain and spinal cord. For the purpose of this talk, I will be spending time explaining the role of disease-modifying therapy and how it helps to prevent further relapses and/or disability accumulation. The history or story of treatments for multiple sclerosis is, in my opinion, very interesting. Prior to the 1990s, there was essentially nothing we could do to prevent a person from accumulating significant and sometimes very rapid disability from multiple sclerosis. In the 90s, the first preventative strategy was approved for patients with multiple sclerosis. This first category of drugs was called the interferon class. These drugs are injectable drugs and work to modulate or change the immune system in a way to reduce the inflammatory actions on the central nervous system. The thought is that interferons help balance the cells within the immune system so that they are not as inflammatory. Shortly behind the approval of interferons came the approval of another immune modulator, though without the interferon component. Many people recognize the name of this drug as Copaxone or glatiramer. This was the next step in immunomodulation. The thought behind this drug is that it essentially redirects the immune system away from the brain and spinal cord. In the 2000s, the availability of new mechanisms of action to target the immune system and prevent accumulation of disability from multiple sclerosis continued to grow. In 2004, the first high-efficacy intravenous treatment for relapsing forms of multiple sclerosis was approved. The name of this drug is natalizumab. Natalizumab works by essentially blocking the blood-brain barrier and preventing immune cells from getting into the central nervous system, effectively preventing the B and T cells from ever even having access to the brain and spinal cord to cause damage. Shortly after the approval of natalizumab, there were several oral therapies that became available. In 2010, S1P inhibitors, fingolimod being the first, received approval. S1P inhibitors work by sequestering or moving the immune cells out of a person's systemic circulation and pushing those cells into the lymphatic system, again, preventing the B and T cells from having access to the central nervous system. Just a couple of short years later, the first selective immunosuppressant was approved by the name of teriflunomide. Medications like teriflunomide work by changing the way a person's DNA and RNA are built and subsequently lowers the inflammatory effects of lymphocytes. The following year, another selective immunosuppressant was approved, this drug by the name of dimethyl fumarate. The exact mechanism of this drug, or more simply, the reason this drug works, is not entirely clear. It's thought that the fumarate class of drug works by protecting the cells in the brain and spinal cord from damage caused by the inflammatory immune responses. We also know that use of this class does sometimes show lowered white blood cell counts, letting us know that this drug can in fact result in immunosuppression. In 2014, there was another giant leap in treatment availability for people living with multiple sclerosis. A monoclonal antibody by the name of alemtuzumab was approved. This drug works by suppressing both the B and the T cells significantly, though temporarily. It's an infusion that a person receives for a few days, and then the B and T cells are subsequently significantly suppressed. And then over the next 6 to 9 months, they repopulate. The following year, the person receives a second treatment, though this time only for 3 days, and again with suppression of B and T cells and then subsequent redevelopment of new B and T cells. The thought process behind this therapy is to essentially reset the immune system with a goal of the immune system unlearning the bad habit of attacking the brain and spinal cord and essentially resulting in a long-term remission state. In 2017, the first anti-CD20 for treatment of multiple sclerosis, ocrelizumab, was approved. Ocrelizumab was the first drug to receive approval for both relapsing as well as progressive disease. Anti-CD20 medications, or anti-B cell medications, work by targeting the B cells. Again, these are the cells giving direction to the T cells and suppressing them to zero, essentially leaving the T cells to go back to their innately learned habits without the poor direction of the B cells. The anti-CD20 class has continued to grow rapidly, with many new approvals since 2017 for various methods of receiving this type of medication. In 2019, another drug targeting both B and T cells received approval in the U.S. This drug is named cladribine. The idea behind this medication is that after the initial 2 years of treatment, the patient would achieve a remission state for several years. It's important to know that the medications that I've mentioned during this presentation are not the only medications available as disease-modifying therapy for multiple sclerosis, nor are they particularly superior to other medications that I did not specifically name. When I was organizing my thoughts, I had planned to not name specific medications. Rather, my initial plan was to only discuss drug classes. My reasoning behind this is because many of these drug classes have since had new medications added since the initial approval of the class. Anti-CD20 therapies are a good example of this. Although ocrelizumab was initially approved in 2017, there are now 4 different FDA-approved anti-CD20 therapies available for patients living with multiple sclerosis, each with unique characteristics that may make one a better option for a patient than another. Although I have given you a very broad overview of the available treatments for multiple sclerosis, it is important to have conversations about available treatments that may be appropriate for you, including the benefits and risks of the treatment for your specific situation with your provider. Thank you for your time.